All right.
All right, good afternoon, everyone. Thank you for joining us today for the Family Medicine Grand Rounds. Next slide, please. So here's the activity code for today. I'll leave this up here for a bit so you can all claim your CME credit. All right, next slide, please. And this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the Grand Rounds will address. Next slide, please. Now we have a brief introduction from Dr. Nato.
Good afternoon. Dr. Kenneth-Nwosa is an assistant professor at UT Health San Antonio and practices sports medicine. He focuses on treating knees, shoulders, hips, ankles at the Medical Arts and Research Center, in the Medical Center, and at the Kyle Seal Parkway location. He treats concussions and specializes in ultrasound-guided procedures and orthobiologics. He completed his family medicine residency at UTMB in Galveston and had the honor to serve as chief resident. He then completed a primary sports medicine fellowship at the world-renowned Andrews Sports Medicine and Orthopedic Clinic in Birmingham, Alabama. He is board certified in family medicine and has a certificate of added qualification in sports medicine. He is the head team physician for UTSA and their NCAA Division I athletics program. He serves as chief medical officer for the athletic trainer residency. He was appointed as a member of the medical advisory committee for the American Athletic Conference in 2023. He is an active member of the American Medical Society for Sports Medicine and has presented at their national meetings. He is active in publishing peer-reviewed articles and newsletters pertaining to the growing scope of sports medicine and non-surgical orthopedics. He was appointed as a holder of the Steve and Mary Ann Lynch Professor in Medicine Endowment. This endowment was created to benefit a promising rising star faculty who is dedicated to the excellence in patient care, teaching, and mentoring of medical students and residents with special interest in orthopedics and other clinical specialties at UT Health San Antonio. So without further ado, I'll turn the floor over to you. Thanks for coming.
I don't think I had that introductions said out loud, and I've been in the same location, so it's kind of very long-winded. I appreciate that though. But so today we're going to talk a little bit about concussions and basically looking at sports-related concussions and the advancements in treatment and prevention. Our objectives today is one is to identify and understand what a concussion is, also define the pathophysiology and discuss the pathophysiology of the concussion, and discuss signs and symptoms and diagnosis and the prognosis of a sports-related concussion, and also discuss the different innovative approaches to prevent the severity of concussion and also understand different types of treatment plans that can go about. So, it's like my introduction said, I am a sports medicine physician. I cover UTSA athletics as a head team physician, and part of my job is to travel with the football team to the different away games and also take care of them when they play in the Alamo Dome. So when I was in fellowship, I kind of had this tradition of standing on the 50-yard line and then doing like a panoramic view of the different stadiums that I visit. So this is last year when we played the University of Tennessee in Knoxville at Neyland Stadium, and there were 100,000 crazy Tennessee fans foaming at the mouth. Unfortunately, it was a pretty big loss, but I still enjoyed the environment. Being a team physician, it's important to understand what a concussion is, of course, and a thorough concussion evaluation is an essential skill. So when we talk about concussions, we're talking about a subset of a traumatic brain injury. The severity can range from mild to moderate to severe. Moderate and severe are more rare than, of course, mild injuries, and what you see the majority of sports injuries being a mild traumatic brain injury. But the severity is based on several factors that include loss of consciousness, bleeding, fractures of the skull or the jaw, and also abnormal Glasgow coma scale, and other things that involve that area. So when it comes to a concussion, it's a complex pathophysiologic process that affects the brain that's induced by traumatic biomechanical forces. So you just know that you have your skull, you have your brain, and you have this space in between it. Essentially, your brain rattles and it creates a whole cascade of events. It can be a direct or indirect blow. So we all know about head-to-head, head versus a ground or head-to-head trauma on the football field, but it also can be indirect. It can be a whiplash effect where now your brain jostles in the skull and it can create a traumatic force, and again, that cascade of events. So normally, it's a rapid onset of a short-lived neurological dysfunction, and the idea is that it resolves spontaneously. The question is how fast does it resolve? Is it resolved in a couple of hours? Is it resolved in a couple of days? And sometimes it can actually take several months to get you back to your normal status. A concussion can occur with or without loss of consciousness, and also when we talk about imaging after a concussion injury, normally acute imaging shows no significant abnormalities, okay? Looking at the NCAA data, we look at the top 10 NCAA sports with concussions, and this is the rate. So per 10,000 athletes, the top sports we see are men's wrestling and ice hockey, but the total number of concussions that we see that are the highest is going to be American football. About 1.6 to 3.8 million sports-related concussions occur each year, and about 50% go unreported. And concussions are most likely to occur in the game rather than practice. And women are more likely to get a concussion in a given sport. But again, if we're talking about 50% go unreported, it's more likely for women or athletes to report their concussions than men. Okay, so when I talk about that cascade of a pathophysiologic process, this is essentially what we're talking about. We're going back to cell physiology. If you remember back in undergrad. So we're talking about the axonal stretch. And when that happens after an injury, your amino acid is going to release. It's going to cause cell depolarization. Remember that, cell depolarization. And the intracellular calcium influx, which decreases ATP. I bet you didn't think you're going to hear ATP today. It decreases ATP formation and increase of apoptosis, which is cellular death, which increases the level of creation of glycogen, which causes hyperglycolysis, which actually breaks down glycogen. And then you have a lactate accumulation, and then that again causes neurodisruption and destruction of the neurons, which is swelling, and also again destruction of those neurons. So essentially, there's a fuel need and a fuel delivery mismatch. Here's another stadium. This one's in Austin, Texas. Delk Royal took this last season or 2 seasons ago. We played them again this season. Wasn't that great, but again, we move on. All right. So for the evaluation of a concussion is very important, and I'm going to give a brief history of the recognition and treatment of a concussion, at least from the NCAA standpoint. So for over 20 years, the International Conference of Concussion on Concussion in Sport has been meeting to define and refine the evaluation and management of a sports-related concussion. The idea of head trauma is bad has always been there, but it wasn't until the turn of century that we realized that this could be a significant problem that needs proper treatment. So if we look at what the NCAA has implemented or tried to implement, we say, we see 1893, they realized, okay, we should probably wear a leather helmet when we play football, right? And then it now transitioned to all football players are required to wear a helmet. 1964, they said no targeting or headbutts during a game because it causes the other player to now be disoriented and possibly sit out the game. And then 73, chin straps and mouth guards. And then 1994, the studies have shown that concussions account for the majority of head injuries and protocols are expected and explored. In 2003, which is, only 21 years ago, that's when the NCAA first had their concussion study published. So it's only been this recent history that we're actually making strides of understanding what a concussion is and how to treat it properly. So the 6th International Conference of Concussion in Sport, they essentially come up with a consensus statement across all governing parties. They have toolkits for screening, especially the SCAT-6 or the Child SCAT-6. They provide systematic reviews to understand, again, what are the proper ways to evaluate and treat. And they came up with the 13 R's, as if we're supposed to remember what 13 R's are. Essentially, I have all the 13 R's right over here. You want to recognize the concussion, so you have to have proper evaluation. You want to reduce the likelihood of them having another injury or having a subsequent encounter of head trauma. You want to remove them. You want to reevaluate. You want to promote rest and exercise. You want to refer to different parties if the concussion's lingering on for too long. You want to promote rehab, promote recovery, start talking about return to learn, return to sport. You want to reconsider whether or not they need further evaluation. Should this player retire after a concussion? And what are some things that we can refine to make concussion evaluation even better? So those are the 13 R's. Okay, don't forget that. All right, so we're going to talk about recognize. Most concussions will be evaluated on the sideline. If you have the opportunity to be on a sideline either for a middle school, high school, collegiate, professional football, basketball, volleyball game, you have to be able to understand these 6 main points. So you want to, number one, understand the mechanism of trauma. How did the concussion occur? Were you paying attention, on the sideline of how a player got hit? Did they have a head-on collision with another player? Did they freeze up? Did they have any type of posturing afterwards? You want to be able to understand that mechanism of trauma. Luckily, at the collegiate and the professional levels, we have something called DV Sport, which we're able to look at an instant replay and rewind and fast forward to the exact hit so we can see how this player came about and did he actually get hit in the head or was it an indirect blow that caused his or her injury. So that's the first point. The second point is when you're evaluating a player, you want to go through the ABCs, airway, breathing, circulation, disability, and the environment of the player. You want to make sure that, are they breathing? Are they stable? Does this need to have an instant referral to go to the emergency room for further evaluation? Does the player need to be spine boarded? So that's what you have to understand, especially if you're evaluating a concussion, the initial evaluation of a concussion on the field before we get to the sideline. The Glasgow Coma scale, normally if it's 15, it should be 15. If it's outside of 15, then they need emergent evaluation. You want to evaluate, like I said before, you want to evaluate for neck pain, see if it's actually a cervical injury in conjunction with a concussion, or is it just a cervical injury alone? If it's a cervical injury, then they need proper spine boarding and referral to the proper location, which should be an emergency room. History. So the history is your conversation with the athlete. You want to assess for symptoms. You want to ask if they have headaches, lightheadedness, dizziness. Do they have neck pain? Do they remember what happened? Do they black out? Has this ever occurred before? Do you feel funny? And that's what you're doing on that sideline, either in a sideline 10 or in the locker room. You're having that conversation with the athlete to figure out if they actually are with it or not. And if they can't answer these basic questions of how the injury happened, then I don't think they should be playing, right? So I think they probably sustained a concussion that has some sort of retrograde amnesia or current abnormalities in their current concentration and orientation. So again, you want to assess the memory, orientation, and concentration, and then you want to do the physical exam. You want to check the cranial nerves 2 through 12. You want to also check their cerebellar function, their balance, their ability to undergo proper testing for single leg stances, tandem gait, forward and backwards, and also do a Romberg's test too. And we'll go over that. That's part of the SCAT-6 examination. So here are some signs and symptoms you should be aware about. I categorize it in essentially 3/4 different categories. Cognitive confusion is a big thing that we see after, as an immediate reaction after a concussion, having a delayed response or slurred speech. Somatic signs, so headache, of course, is the number one symptom that we see. Photophobia, which is sensitivity to light. Phonophobia, sensitivity to loud noises. Having balance problems, nausea and vomiting, dizziness. The affect and sleep. Emotional liability is one that people ignore or people don't understand. Is that a player or a patient can get very irritable, or they can get really angry with you on the sideline. It's something that is especially not their norm. I did have a patient, a volleyball player in the past that we were unsure whether or not she had a concussion, but then she revealed to us that she has been more irritable than normal, that she was after that hit, she had a conversation with her mom and she was shouting on the phone with her, and that never happened. So that is one of the symptoms that we have to be aware about that probably isn't discussed widespread. If they have sleep problems, if they're drowsy, or if they have problems sleeping throughout the night or trouble falling asleep, that's also a concern. So these three tests are evaluation forms are within the consensus statement from the Sixth International Conference. The concussion recognition tool is a great tool for individuals that aren't in the medical field, but maybe they're on the sideline, a parent, a sponsor, and they see a concussion. This is a great tool to use because it, again, talks about those red flags of neck pain, of seizures, loss of consciousness, loss of vision, and allows them to figure out the appropriate steps. The best thing about these toolkits of the SCAT-6, Child SCAT-6, and the CRT is that you can literally just read through it and it tells you exactly what to do. So it takes the brain power off of you a little bit, and allows you just to go through the process and really identify a concussion properly. So for sideline management of concussions, the diagnosis is largely clinical. Like we talked about, the SCAT-6 or basic balance testing. You want to look for the red flags, which are prolonged loss of consciousness, vomiting, neurological signs, severe neck pain, worsening mental status, and also having a decreased level of consciousness. Posturing has come up pretty recently, just due to the sites that we're seeing on an NFL field, which is decorticate posturing, which is damage to that corticospinal tract due to a traumatic blow to the head and neck. It disrupts the control of motor function, which leads to a loss of inhibition, and that's causes overactivity. And then the athlete can get into a primitive response to a traumatic brain injury, which will involve having your arms closer to your body and flex wrist and abnormal movements with your fingers. So unfortunately, that's what we saw multiple times for Tua Tagovailoa, and that's why he's currently on the NFL injured reserve, trying to recover from, I believe, his fourth concussion in the past 2 years. All right, so this is what we're trying to avoid. This is why we're on the sideline. This is why physicians and other providers are on the sidelines, because we're trying to prevent second impact syndrome. Second impact syndrome can occur when an individual suffers a second impact after not fully recovering from a concussion. So that's the biggest fear. The biggest fear is that a individual is improperly evaluated, goes back out, and then suffers another traumatic blow to the brain. It can have a catastrophic outcome. It can lead to a loss of autoregulation, increases in intracranial pressure, which leads to brain herniation, coma, or death. There is like I talked about, there is a vulnerability period where a high school athlete or a college athlete or any athlete that suffers a concussion has to recover properly and get back to their normal state. Otherwise, too soon after a concussion, the brain is still healing and it's susceptible to further trauma. So that's why we promote prevention, which is going through a proper concussion protocol. Everybody knows about concussion and Will Smith's terrible African accent. I could say that because I'm Nigerian. Just it didn't hit well with me a little bit. So he played Dr. Bennett Omalu, who made a great groundbreaking discovery of chronic traumatic encephalopathy. It was first identified in the 1920s as punch drunk syndrome in boxers who repeated multiple blows to the head. But with chronic traumatic encephalopathy, the theory and the idea is that after repeated blows and on any type of level, whether it's high school, college, or professional levels, it basically creates another pathophysiological cascade, which creates tau proteins and neurofibrillary triangles that basically delay the response and delay the regulation and the activity of the brain. So this has, again, CTE is on the tip of everybody's tongue, and the NFL knows it, and other entities understand the importance of managing concussions properly due to the possibility that CTE can be further proven after repeated blows to the brain. Okay, so this is why I don't know I had this slide, so I just kind of summarize it. But the tau protein and neurofibrillary tangles, they disrupt normal neurological function and contribute to cell death. There's chronic inflammation that further damages neurons and exacerbates tau pathology during a CTE. And then over time, the accumulation of the tau proteins and leads to progression of cognition, decline, memory impairment, mood disturbances, and behavioral damages associated with CTE. Any questions so far? No, there's also be questions at the end. Time to answer questions at the end. This was West Point, so we played Army 2 years ago at Army. It was really cool. They had the cadets are mandated to, it's mandatory for them to be present at the games. So there's about 500 cadets in the student section, all with shaved heads and, buzz cuts and wearing their fatigue, and they get very rowdy. So it was an awesome experience to see UTSA play Army, and we actually get to go back November 30th this year too. All right, so remember those 13 R's? Yeah, we just did one of them. So now we're talking about remove. So it's important to remove the athlete from the environment of where they experience trauma. and undergo the SCAT-6 or the child SCAT-6. The main difference is the SCAT-6 is used for individuals above the age of 13, and the child SCAT-6 is good from the ages of 8 to 12 years old. The optimal time frame is within the first 72 hours, and then maybe up to 7 days you can use the SCAT-6 questionnaire form. So I'm going to click through. I wonder, will it present if I click through this link, the SCAT-6? Will it present if will it still present if I'm able to click through this? Okay, so it's looking, it's okay.
So I think I'll just say click back on the PowerPoint when you're done and it should.
Okay, perfect. So this is what a SCAT-6 is. It's free. You can print it out. You can bookmark it, especially if you have individuals that you're seeing in your clinic and you're concerned with a concussion. It's essentially it's essentially a questionnaire for the athlete and or parent for their athlete, but it's also a guide for you as a physician or a healthcare provider. It goes through the different areas, and I can kind of show you briefly what it looks like. So essentially you fill out the form. The athlete can fill out this form. Talk about concussion history. They also have a guideline of what you should do for an immediate evaluation, especially on the sideline. I mean, it's something that you should memorize. I don't know if it'll be a good idea if you're on the sideline and you're looking at a piece of paper trying to assess them, but it provides observable signs like what we talked about. It provides red flags and also how to assess the cervical spine. And allows you to document it properly so that you have a foundation of evidence that you can rely on, especially during the athlete's recovery period. So again, this is a symptom evaluation that the athlete that you hand the form to the athlete. They're able to rate their symptoms from 0 to 6, and they're allowed to kind of explain why they're not feeling 100%, and you're able to fill in that information too. After they fill this out, you calculate the total number of symptoms and total symptom severity score. So what's important for this is that once you have this SCAT-6, you're able to now follow up with the athlete and figure out if their total number of symptoms are decreasing or if their symptom severity scores are decreasing in subsequent encounters that you may have in your clinic or at their training room. So they go through proper orientation. What month is it? What day is it? You talk about immediate memory. So the SCAT-5, which was the version before this, only had 5 words, but the SCAT-6 now has 10 words, which is pretty intense. Sometimes I even lose concentration on trying to memorize the 10 words. But they give you lists on what you should do. You should do the trial 3 times. Essentially, the SCAT-6 takes about maybe 15 to 20 minutes if done properly on the sideline or in the locker room. And my idea is that if you do know that the patient is getting irritable or the patient can't even complete a SCAT-6 because of their symptoms after a traumatic hit, you could probably stop it and say that, hey, you can't go back in. We'll reevaluate you tomorrow, or we'll reevaluate you on a day that you can get into my clinic. So they also, part of this is reading a number forward and them repeating a series of numbers back to you backwards, where you say 493, they'll say 394, and then you add a number to the end of that series and see if they can continue replying back to you. Saying the months of the year backwards. Some people are really good at that. It's pretty impressive. And then we get into the modified balance error scoring system, or the MBES or BESS scoring, in which we test right or left foot. We allow them to go into different stances to see how they can tolerate their own balance, and seeing if their vestibular and cerebellar function is intact or hindered. So I'll show you what those gates are. I have some pictures that shows you exactly what it is. So this is they also have a delayed recall. So you ask them, do you remember those 10 words that I talked about in the beginning? And then you have a total cognitive score. So, the SCAT-6 is a great tool to have. Again, you want to bookmark it. You want to print it out. You want to laminate it. You want to use it. You want to be able to use that in your clinic and on the sideline. Also, you can use this as a baseline. So if you have any particular, you're doing a sports physical, and you want to actually get a baseline SCAT-6, it'll be great for that athlete, because if they do have any type of a concussion, you can see what their baseline is, because maybe maybe they have a history of a learning disability, and they can't really memorize or recite back 10 words, or they recite back 5 words, and they're completely normal. And somebody else evaluates and they're like, okay, well, this person can only cite back 5 words, and they're out. You won't be back in until you can recite more than 5, but that's outside their baseline. So it's always good to have some type of baseline testing, and SCAT-6 is something that you should consider implementing, especially if you see somebody for a sports physical and it's part of that sports physical package you can provide an athlete. So the NBA actually uses a version of the SCAT-6 for their baseline testing, which we implemented, which they've been implementing, and we've had the opportunity to perform baseline testing. I think it was last week before the preseason, so been pretty good. All right, where's the PowerPoint? Is it this?
Yeah.
Okay. All right, and then I can do full screen.
You should be able to just click back on it, and it should.
It's not that full screen. Probably this.
Yeah.
Oh no, that's end show.
Try clicking and show, and then we'll put it back up,
Okay,
back to.
right here.
That was,
There we go. Awesome. All right. So we talked a little bit about the SCAT-6. We went through it. Any questions on that questionnaire or that form? Uh-huh.
So if you pull an athlete off the sidelines after concussion, it's their SCAT-6, it's pretty clear they're having symptoms clinically and on the objection or objective scale. When you see that athlete, can they stick around? It's a silly question, but stadiums are loud, there's a lot of lights, there's a lot of stimuli. Can they stick around, or you send them to the locker room, or what do you do?
So my recommendation is always go to a more controlled environment, because you have bright lights, you have loud, like you said, you have crowds, you have loud noises. So I always recommend sunglass. If you're going to be on the sidelines, you have to wear sunglasses or earplugs or big old noise canceling headphones if you want to be on the sideline. But typically, I tell them to be in the locker room. So our protocol for UTSA is that they're in the locker room, they shower, and they stay in the locker room with the athletic trainer until the end of the game. And either they can go home with their parents, or they're going to go home on the team bus. So it's typically not great for them to be on the sideline. Yeah, good question. All right. So these are the stances I was talking about. You have the single leg stance all the way to your right. You have the tandem left foot in front of the right foot, and you have the feet together. And this is how we observe their balance. All right. So this is if you come away from this presentation with anything, it's going to be these 2 statements. They rhyme, right? So no same day return to play, right? So if you believe a athlete suffered a concussion, they should not return to play within the same day, okay? Even if you're suspicious. So this is important, especially for sports that may have double headers, right? So if you have a baseball athlete that suffered a concussion, they're like, okay, well, I feel fine for my 4 o'clock game. Can I play? No, No same day return to play. Okay. And then also when in doubt, sit them out. When in doubt, sit them out. So even if if you're not 100% sure, you're leaning on the border, you know, you know, you want to just you want to sit them out. Don't cause any trouble. Just sit them out and reevaluate when you're in a more controlled environment. All right. So the other part of a concussion is rest and exercise. So after a concussion. So know that there can be worsening factors, especially in patients that may have suffered, in patients that suffered concussions, that if they had any type of previous concussion, if they had a long duration of symptoms, increased number of symptoms. Studies have shown that young adolescent women tend to have a harder time getting back after a concussion. Those with like poor techniques, aggressive play, maybe they will have a longer time that could worsen and increase the duration of their symptoms. ADHD or any learning disability, headache disorders and migraines, and if they're on any type of anticoagulation medication too. So imaging is essentially not necessary. CT is the gold standard for emergencies. So just know what an emergency is. So we talked about those red flags. That's when you would refer to an emergency room, and they most likely will undergo a CT scan to look for any type of bleeding or abnormalities within the brain and cervical spine. All the other ones, MRI, you normally use that for individuals that have a longer bout of symptoms, 4+ weeks, several months, and they're not getting any better. fMRI, all DTI, MRI spec, those are very rare things that we don't really need to go over. Neuropsychological testing. So essentially testing, processing, speed, memory, overall cognition, cognitive function. The more popular testing is called the impact. I don't know if anybody's heard of impact testing. So with impact, a lot of high schools use it in the state. They create a preseason baseline. So it's essentially like the SCAT-6, what I talked about of creating a preseason baseline, but it creates a baseline that goes beyond just goes beyond the form. It's more of a reaction time to certain things. It has you draw a certain figure on the computer, and it makes you remember and kind of touch things, and a bright light will pop up, and you have to touch it with the mouse and do all these things. So it creates that psychological baseline testing that can help you understand if an athlete's ready to go back to the field of play or not during the concussion return to play protocol. The one that we use at UTSA is something called SWAY, and it's basically like impact testing, but it's in the phone. It's an app that all our athletes use. So when they have their preseason physical, they all just log on to their app. They do all the different testing to see what their baseline is, and it's a pretty thorough examination. They have to do it 3 times, and it creates a great narrow precise testing that we're able to now evaluate when they have a concussion and compare and contrast to their baseline testing. So as they're recovering, we like to see a resolution of concussion symptoms at rest. We want to be able to test them properly without any abnormalities and have them return to learn and sport when they reach their pre-injury level of function. So return to play, typically we want them to be asymptomatic. The newer language is maybe they have 1 or 2 symptoms before you start the phase 1 of the return to play process. You want to be able to monitor their progress over the return to play protocol, and also tailor their protocol to individual access. If they're able to follow up closely, if they're not, maybe need to do telemedicine, maybe need to do self-reporting. And if they're not improving, do you consider doing a referral to physical therapy or occupational therapy to work on vestibular training or a vestibular rehab? Or do you need to send to a neuropsychologist or an ophthalmologist to further enhance the return?
For the neuropsychologists, I mean, they do neuropsych testing. What else do they do? Is there treatment options there?
That's a very good question. They don't really have any type of treatment option. Is more of providing another level of assessment. Because essentially if they see that it could be either depression, anxiety that's contributing to the lingering symptoms, we will have to understand, do we need to refer to now a psychiatrist or possibly treat that underlying mood, the mood and the symptoms, or we find out it's something else that we actually need to involve a neurologist and get an MRI and go from there. But yeah, that's a good question. So the return to play protocol is outlined into a 6-step process. Step 1 is symptom limited activity. Step 2 is aerobic exercise from light to a moderate level of walking, stationary bike, and using an elliptical trainer. You want to be able to increase their heart rate, and their heart rate should be around 55 to 70% of their max heart rate. Step 3 is more sports specific exercise. And also for each step, it's a day. It has to be 24 hours. You can't go through all 6 steps in one day. You can't split it up within 2 days. It has to be one day, and you have to evaluate if they had any symptoms after undergoing that step. So step 3, sports specific exercise, shoot around drills, soccer juggling, baseball long toss. You're adding that motion and coordination, and it increases that aerobic challenge. Step 4, non-contact training drills. So running drills, pass patterns. You're now working on your cognitive challenge. And again, you're increasing that aerobic exercise. And then step 5 will be a full contact practice where we're now assessing if they're ready to be, if they're ready to play in the game. And if they complete that, step 6 is return to full competition and they're undergoing normal gameplay. So typically during the football season, football is great because it's a week between games. So if they're able to recover after a game, they're most likely able to play the next week. So if you ever see something like, hey, didn't they just have a concussion last week? But yeah, it takes less than a week to recover from a concussion if their symptoms are limited on that Saturday or on that Sunday after that game. So return to learn, especially important for student athletes. You want to minimize time away from school. Usually, it's thought that, hey, we should put them in a dark room. We shouldn't, put a book in front of them. We should just seclude them. No, we don't want to do that. We want to make sure we work to see what they can tolerate. We want to provide them the opportunity to either have longer times taking quizzes or tests in order to perform to the best of their abilities at that level that they're at. So studies have shown that student athletes that suffered concussion, they actually achieve full return to learning without any type of academic support by 10 days. Full return to learn should be incorporated before unrestricted return to play. At UTSA, we have an academics office that we work in collaboration to make sure that they have all the academic needs met as after they sustain a concussion, whether that's, again, providing more time for quizzes or tests, providing proper tutoring, allowing delays in turning in homework. And the difficulty right now in this in the past couple of years that everything is now online, is on a computer screen. So whether or not they can tolerate actually reading and doing homework via video and also on a computer screen. So referred is what we're talking about. If there's persisting symptoms that are greater than 4 weeks, you definitely want to refer and try to figure out a collaborative approach on understanding why these symptoms are lingering, whether that's, again, referring to a neuropsychologist, referring to a neurologist that specializes in concussions, which we now have at UT Health, which is great, or possibly talking to an ophthalmologist or a vestibular rehab specialist to be able to see how we can get them back and understand what's delaying them from recovering. So this was in Orlando during a bowl game. This was at a soccer field, which is pretty awesome. So I'm just showing all losses. We lost this game too. We beat Army though. We beat Army. I'll say that. So there's been a lot of innovative approaches for prevention and recovery. And I think that's what makes the concussions and the study and the progression of it very interesting. Typically, for athletes, we like to use fish oil because it may provide some type of anti-inflammatory property. It may support the structural integrity of brain cell membranes. Again, most of everything now is just like, does it work? I don't know, but can it work? Yeah, I guess. Does it harm the athlete or patient? Probably not. So we would like to try things to help augment their recovery and help support their recovery and speed it up to make sure that they feel comfortable getting back on the field again. So again, mixed research outcomes. Fish oil can aid in recovery, but it's not, the evidence is not conclusive. And again, further research is needed if it actually makes a difference. So neuromuscular training, this is something that we use at UTSA. It's called a tracer, especially in those that we see that there's significant vestibular issues and hand-eye coordination issues and balance issues. We like to use a tracer, which provides, again, a more body-intensive neuromuscular functioning in which you are now moving your body in a certain way and responding to stimuli that you see on the screen, whether it's raise your right hand up, raise your left hand up, look at a certain space, try to move from one point to another. It allows for those individuals that are recovering for a concussion to really try to exercise and support themselves to see if that can help promote them get back on the field or court in a expedited time frame. Another thing that's kind of questionable is whether prolotherapy with dextrose or Botox can help. It's possible, especially if a lot of the pain is coming from headaches and maybe they have lingering symptoms due to tension headaches or due to the muscles on their skull that's contracting and causing discomfort. It's possible that injectables could relieve the tension and pain during recovery. The big one right now that we talk about is a Guardian cap. So I don't know if anybody's ever seen the Guardian caps where it looks like a mushroom on top of their helmet. Dr. Alan Seals, the NFL's chief medical officer, states that the use of Guardian caps has shown a 50% reduction in concussions among position groups in our early testing. So essentially what the Guardian cap does, it provides an extra layer of padding on top of the helmets to reduce impact. Stanford looked into it. They say that there is inconclusive evidence. We're not exactly sure where Dr. Alan Sills got that 50% reduction because there isn't any printable or objective data that we can say that it actually had that reduction. But the controversy is really on this. Will this actually help, or will players be more reckless in the way that they are conducting? Because like we talked about, concussions are about direct and indirect hits, right? So there is even controversy on whether or not helmets are the reason why players are getting concussions, right? So if I know that no matter what I do, if I dive, tackle, and if I lead with my head to hit a player, I can probably, and I know I'm not going to get hurt, I may aim for their helmet. I may recklessly lead with the crown of my helmet, leading to further damage because I know I have a protective piece on top of my helmet or my helmet in general. So that's why the people you can debate that rugby is safer because they actually tackle. They do different types of techniques in tackling that decreases the likelihood of concussion, and that's because they don't have significant head and helmet protection that the NFL does. Does that kind of make sense a little bit? You could be a little bit more reckless if you know you have these certain protective factors. But again, Stanford studies, Sichi et al. Said that there is inconclusive evidence whether or not Guardian caps could actually prevent a concussion. And again, another way to think about it is that you have an egg in a bowl, right? And you're wrapping the bowl with saran wrap and bubble wrap and foam and everything like that, but the egg is still in the bowl. So if I go like this, even though it's wrapped with saran wrap, I can still break the egg, right? And that's kind of like what's happening with the brain. All right, so another another theory of advancement for preventing concussions is the Q collar. Has anybody heard of the Q collar? Okay. What'd you hear about? You look excited.
Always wondered if this like actually beneficial. I've seen players, and even like in high school now, I've seen it wear them, and I've just always been curious about it. So I'm excited to like hear about it.
Yeah. Okay. Just one slide though. So I'm just kidding. I'm just joking. But so the Q collar. So you have the idea behind the Q collar is that there was a study that showed that there was a 30% lower risk in concussions when a sport is practiced at altitude. So the theory was that the increase in intracranial pressure at altitude was thought to lead to reduction in intracranial space, thus reducing the force and speed at which the brain encounters the skull walls during impact. So essentially what the Q collar does is put pressure on the on the jugular vein, right? And it basically allows there to be more pressure. And essentially we can go back to the egg in the bowl thing, right? So we can say that there was Jello in the bowl with the egg, right? So if we put more Jello around it or make Jello more dense, maybe the egg stays still, right? So that's essentially what it's trying to do, is trying to increase that pressure of the fluid around that brain so that if something happens and you're having that brain jostle around in the skull, that it can actually stay put and be more protected. So that's the theory and the idea around that. So the creators of the Q collar now created something that can put pressure on the jugular vein, and the theory again is to prevent concussions. There's inconclusive evidence on whether or not this works. So yeah, the studies are still out there, and the controversy is that the maker of the Q collar is the only person that actually had this. That the maker of the Q collar was the individual that came up with this theory, right? So like the maker of the Q collar first came up with like, oh, there could be, decreased concussions and a low risk for concussion at altitude. And then that's the science behind the Q collar, and that's the science that everybody's been pointing to. So there's kind of like a conflict, there's kind of like a bias in understanding if it actually works or not. So I do use it for my athletes because, again, if there's something that can decrease the risk, we definitely want to try it. If you're ever able to go into the NCAA ranks, the NFL, NBA, everything's about innovative approaches and kind of like separating, crazy ideas and things that are just going to trying to fund somebody's mortgage versus like actual something that can be beneficial for the athlete. And you kind of have to tease out some of those things. And this is one of the things that in theory could possibly work. It's very sleek. It allows, the players don't really notice it when they're playing with it. It doesn't cause any type of headache, doesn't cause any type of neck irritation, no dizziness, no lightheadedness. It's something that could possibly be very, very beneficial. So I'm going to try to take my anecdotal evidence to see if it's something I want to do in the future with these athletes.
There's like one size fits all, or there's like custom made to fit exactly your neck.
So it's custom made. So they have they have a sizing protocol that you have to now turn in to the Q collar company, and they will send you a custom fit Q collar. Okay, so this was I'm also a team physician for Brandeis High School, so this was kind of a I don't know, it's cool. Gus Fair Stadium in San Antonio. Always appreciate high school sports. So so this is something that anybody can do. Get a certificate of completion from the CDC's Heads Up for a Safe Brain and a Stronger Future. It's an online concussion training tool for school professionals, coaches, parents, sponsors, physicians, healthcare providers. If you're interested in just kind of learning proper tackling techniques, learning how to identify concussion. This is something that is great, just to give anybody in the community. So this is my last slide. Does anybody have any questions or concerns?
Did you say you're using the C collar right now?
Yes, I'm using the Q collar. Yes. Yeah. Mhm.
How much does it cost, you know?
Man, I don't know. Yeah, I'm not exactly sure. We don't really look at price tags in that sort of level. We just like do it. But I'm pretty sure you can order it individually. There is an individual market for it that you're able to go on their website. I'm not paid by them. I don't have any type of connection, but you can probably go on their website and look at the pricing.
Well,
Yeah, a lot of schools use it. They use it in the NFL. I've seen high schoolers use it, and it's possible that it could be beneficial. No, not mandatory. No, not all my players are using it. No, only certain. I mean, out of 450 athletes, probably 2 or 3 are using it. Yeah, and those are people that could have a higher risk of concussion due to previous concussions, and we're trying to prevent any further episode of another concussion. Yeah, in theory, right? So this is all theorizing that it may help.
So, one of the R's that I memorized was
Mhm.
fine.
There we go.
And so when it comes to, getting a player, pulling them out, returning them to play, ideally 6 days, right? 6 steps, 24 hours per step, maybe sometimes longer and sometimes prolonged. Let's say they're 6 months out from injury, they're still at a higher risk of a repeat concussion, right? Because of axonal strain and injury and all these other reasons. What do you do typically to refine their behaviors or their lifestyle or anything to try to avoid it?
I mean, it's always good to understand, and that's where the heads up gets is best, especially in high school or middle school athletes, is that they have to understand, especially if it was with the hit, are they using proper technique to tackle? Are they using proper techniques to head a ball in soccer? Are they protecting themselves in cheer, right? So cheer is probably the majority of patients that I see for concussions, because it's under they are not educated, or it's not emphasized on proper techniques to protect them with basket tosses, with different types of stunts. And then also it almost seems like it's frowned upon to talk about your symptoms when you're in chair. It's a very, very tough sport. So they try to keep everything internalized. So it's important to have that conversation of saying like, hey, like, let's make sure do you need to rehash how to tackle properly? Do you need to rehash the importance of safety, the importance of doing things in a proper protocol manner? So yeah, it's and on the NCAA level, I've had discussions with different athletes about, hey, this is what we need to do. This is what we need to do to make sure we prevent this from happening. You got to protect yourself this way, and also working with the athletic trainers too. Any other questions at all? Well, I appreciate y'all's time. Thank you so much. I think third years y'all get to rotate with me. So I really appreciate you coming by my clinic too. Yeah.
So just as a small token of our appreciation.